Hello, this is Madanigma, and today we are continuing with our dermatology section. And today our topic of discussion is psoriasis. Now let's take a look at this. These are our learning objectives. In this lecture, we will be discussing about the definition of psoriasis, its pathogenesis, how does psoriasis occur, clinical features, what are the clinical features of psoriasis, what are its different types, aspects, and Koebner phenomena, which is quite important with respect to the clinical point of view as well as exam point of view. Next, we will be discussing about the nail changes in psoriasis. Then we will discuss psoriatic arthritis, triggering factors of psoriasis, because this is a condition which gets triggered by various factors. So we will be learning about those factors. Next, we will understand about the management of psoriasis. How can we manage a patient of psoriasis? Finally, we will be discussing about the complications of psoriasis. So these are our learning objectives for this lecture. I have divided this lecture into two parts. In the first part, I will be covering psoriatic definition, pathogenesis, clinical features, aspect, sign, and Koebner phenomena. In the next part, I will be covering the remaining topics. Okay. So let's begin. What is the definition of psoriasis? So psoriasis is a chronic immune-mediated inflammatory skin disease. What does this mean? It means chronic. It is a chronic condition. It goes on for years and months, not for the days and weeks. So it is a chronic condition, immune-mediated. Okay, just let's understand what does this mean. It means that in the body, remember, in our body, we have got two types of immunity: innate immunity and adaptive immunity. In adaptive immunity, we have got two further types: B cell mediated and T cell mediated. Now, that T cell mediated immunity is basically involved in the formation of psoriatic plaques. So, here we will be discussing about T cell mediated immunity. So, T cell immunity is involved in psoriasis. Inflammatory skin disease, inflammatory, that means we will be seeing all the five characteristic of inflammation, that is heat, pain, redness, and loss of function. Okay, next it is a skin disease, which is characterized by well-defined erythematous plaques, silvery white scales, symmetrical distribution, and chronic relapsing course. So this is what exactly. Now take a look at this in this picture. It is well-defined erythematous plaques. What is a plaque? It is basically a raised lesion, more than 1 centimeter raised lesion. That is, it is above the skin. Okay, erythematous, you can see the redness here, well defined. It has a clear boundary. In tinea, you also see a clear boundary, but in the tinea, lesions are basically are usually divided of a center. So basically, their center is clear. But here, you can see that the center is also red and the periphery is also red. So it is well-defined erythematous plaques that you will be seeing in psoriasis. Silvery white scales, you can see them. And then symmetrical distribution, it often involves the same part, the same site of two different parts of the body. Okay, like if it occurs on the elbow of one side, then it will also occur at the same side of the elbow on the other part, on the other side of the body. And finally, it has got chronic relapsing course. That means it appears and then disappears. It gets triggered and then appears, and then finally gets resolved, and finally it again appears. So it has a chronic relapsing course. That's why it becomes chronic condition instead of an acute condition. Okay, so but exactly psoriasis, it is a chronic condition, immune mediated. Mainly T cell immunity is involved in the formation of psoriatic plaques. Inflammatory skin disease, which is characterized by, you will be seeing a well-defined erythematous plaques, silvery white scales, symmetrical distribution, and chronic relapsing course in the case of psoriasis. So this is definition of psoriasis. Now let's talk about its distribution. Where does this psoriasis occur? It basically involves extensor surfaces such as elbows, our knees, then scalp, sacral region, lower back, nails. In nails, you will be seeing pitting, which often occur in the severe form of psoriasis, pitting of nails. Okay, if this is important, it has got bimodal patterns. What does this mean? It means that in type 1 psoriasis, it usually occurs in younger people, in younger adults, like in 15 to 30 years of age. Such people are often presented with psoriatic plaques, and it is more severe and genetically linked. It has got stronger genetic link. That means it occurs in young people. It is more severe, and it is specifically associated with the family history, with a positive family history. Next, in the second part, we have got type 2 psoriasis. So type 2 psoriasis, it occurs in older people, mostly involving 50 to 60 years of age, and it is milder as compared to the type 1 psoriasis, and it basically it has less genetic association. So we have got bimodal patterns. Often we would be seeing young patients with more severe and genetic association, and then we might be seeing an older patient in which psoriasis is not that much severe, and it often has less genetic association. Family history might not be positive in those patients. So it has got bimodal pattern, type 1 and type 2. So this is all about the distribution. Next we are going to talk about the pathogenesis of psoriasis. Take a look at this picture. So here we will be discussing about the development. How does psoriasis occur? So it all begins with the inflammatory trigger. As I already mentioned, that triggers are quite important because they basically allow the psoriasis, the whole process of psoriasis to begin. So we have got inflammatory trigger. They could be injury, infection, allergy, chemical, and stress. All these are the triggers which affect the normal skin. And once the normal skin is triggered by these inflammatory reactions, then what happens that in the skin we have got antigen presenting cells which are called dendritic cells. Dendritic cell basically antigen presenting cells, and Langerhans cells is basically one of the type of dendritic cell. So these antigen presenting cells become activated. What do? They basically secrete these cytokines. These are chemical mediators. For example, interleukin-1, 6, tumor necrosis factor alpha. These are the cytokines which are released by the activated antigen presenting cells. Now, what happens then next? Basically, these activated Langerhans cells, they basically migrate towards the skin lymph node. There they activate T helper cells. T helper cells become activated, specifically T helper 17, that is CD4 positive T helper cells. They become activated. They further secrete a set of chemical mediators like tumor growth factor beta, interleukin 6, interleukin 23. Those are basically they activate the T helper 1 cells, and the 17 cells. They further secrete interleukin 17. Now that interleukin 17 causes all the psoriatic plaque formation. How does it causes that? Basically it increases the proliferation of the skin cells. So these keratinocytes start proliferating too much. They don't even shed off. So we have got a pile of dead keratinocytes. So that pile actually causes the raised lesion which we see as a plaque. Okay, so take a look at this. The development of psoriasis is thought to be precipitated by an inflammatory response in the skin. So we have got an inflammatory response in the skin which is often triggered by injury, infection, allergy, chemicals, or stress. So these inflammatory triggers activate the normal skin cell. Now what does happens? The innate immune cells such as Langerhans cells, they are normally present in our skin. So they become activated. They produce pro-inflammatory cytokines such as interleukin-1, 6, tumor necrosis factor alpha. These are the cytokines. These are the chemical mediators which are released by the activated Langerhans cells. Now, what happens next? These activated Langerhans cells then migrate to the skin lymph nodes. What do? They present antigens to the CD4 positive T cells. So basically, they've got the antigen. Now they are gonna present this antigen to the CD4 positive T cells. Production of tumor growth factor beta, interleukin 6, and interleukin 23 stimulates differentiation of T cells into T helper cells. So basically, T cells, these CD4 positive T cells, become activated or become differentiated into T helper cell in the presence of these cytokines. Okay, and that migrate into the skin. Now these activated T helper cells, these activated T helper cells will go to the skin, they migrate towards the skin, and there they secrete interleukin 17. Keratinocytes become activated by interleukin 17. This interleukin 17, what does it do? It basically activates keratinocytes which are present in the skin, and under that stimulation, they secrete additional cytokines that attract other immune cells to the skin. And not only this, interleukin 17 actually causes a proliferation of the keratinocytes, but T helper cells, this activated T helper cells secrete other types of cytokines which even attract other immune cells to the skin, and that results in the self-perpetuating inflammatory process in the skin. So that's how the inflammation begins in the skin. That's how due to the proliferation of keratinocytes we get to see a plaque formation. So this is the whole process of a complete psoriatic formation. Now we will be discussing it step one by one. So first step is the immune activation. How does immune system activates? Trigger activates dendritic cells. We have got different types of triggers, as I already mentioned. They activate dendritic cells, and those dendritic cells, they migrate to the skin lymph nodes. There they basically they present antigens to the T lymphocytes. Then T lymphocytes basically become activated under the influence of cytokines, and that then they gets converted into activated T helper 17 cells. They release cytokines, which tumor necrosis factor alpha, interleukin 17, and interleukin 23, and interleukin 22. So this is the first step, immune activation. Next step is the keratinocyte hyperproliferation. Once the activated T helper 17 cells migrate towards the skin, and there they release the interleukin 17, then what happens? That under the influence of cytokine interleukin 17, these cytokines stimulate rapid keratinocyte division. That is, we have got the proliferation of keratinocytes, abnormal differentiation. Because of this, the keratinocytes, they don't get to differentiate properly. So we have got abnormal differentiation, incomplete maturation. So even the keratinocytes don't even get to mature properly. So normal skin turnover, which takes usually 28 days. Normal skin turnover, that is, new cells are formed in the basal layer, and then they migrate towards the stratum corneum. That turnover, and then they get shed off. So this turnover usually takes 28 days. But in psoriasis, this turnover gets shortened to the 3 to 5 days. So can you imagine that from 28 days we have got the turnover to 3 to 5 days? So what does it do? That causes thick epidermis. We see thick epidermis in the form of plaque. Parakeratosis. What does it mean? It means nuclei retained in the stratum corneum. Usually, in the stratum corneum of epidermis, we don't see any type of nuclei because they are usually dead cells. But here we will be seeing nuclei. Why? Because of the incomplete maturation. They do, keratinocytes. They usually, when they migrate from the stratum basal towards the stratum corneum, they during this whole process, during their migration, they actually evolve. They actually mature, and then finally they shed off their nuclei and go to the stratum corneum. But we already mentioned that in psoriasis there is incomplete maturation. So these during the migration, these keratinocytes they don't get to shut off their nuclei, so they retain their nuclei in the stratum corneum, and that process is called parakeratosis. Okay, and finally we have got scaling. So this abnormal skin turnover causes thick epidermis, that is plaque formation, parakeratosis, that is nuclei retained in the stratum corneum, and finally scaling. Next, third step, what does happen? Increased dermal vascularity. So what does it means? It means that there is capillary dilatation under the influence of those cytokines. There is capillary dilatation. The capillaries in the epidermis, in the dermis, that those capillaries become dilated, and then increased blood flow. There is increased excessive blood flow towards the skin, because of which we see the erythema. Erythema is the redness. That is basically due to the increased blood flow. And finally, this explains erythema, that is redness. Aspect sign. What is aspect sign? It is the bleeding when scale removed. When we remove a scale, that then we will see a pinpoint bleeding. That is called a positive aspect sign. So that why does it happen? It happens because when we remove the scale, because there is already too much blood under the skin, under the scale. So once we remove the scale, that blood starts oozing out. So we see the aspect sign. This is the histopathology, which is quite important, that once we see a lesion of psoriasis under the microscope, we see hyperkeratosis, that is too much keratin in the stratum corneum. Then we see parakeratosis, that means retained nuclei in the stratum corneum. Finally, acanthosis. What does acanthosis? It means thickening of epidermis, and I already explained you why does this thickening happens. Acanthosis, elongated ratty ridges. It is a very important from the exam point of view. Test tube in a rack appearance. So this gives rise to test tube in a rack appearance. Elongated ratty ridges. Monroe microabscesses, which means neutrophils in the stratum corneum. Usually, the neutrophils don't lie in the stratum corneum. They often exist in the dermis, but here we will be seeing the neutrophils in the epidermis, especially in its stratum corneum layer. Dilated dermal capillaries. So take a look at this. This picture will show you everything. Hyperkeratosis, we get keratinocytes retain nuclei in stratum corneum. That is called parakeratosis. Too much keratin and then finally retained nuclei. Acanthosis, increased thickness of epidermis, elongated retiridges. You can see these are the retiridges. These you see here. So these are the retiridges, and they are usually in the normal skin. They are usually somehow this much. That if they are not that much elongated, only mild dilatation. But here we will be seeing they are penetrating into the dermis, and this appearance produces a test tube inner rack appearance. This is called test tube inner rack appearance. So we have got retiridges which are elongated, and then finally micro Munro microabscess. Okay, so these are the Munro microabscess in the epidermis. They usually don't occur in the epidermis, but here we will be seeing neutrophils in the epidermis. And finally, we have got dilated capillary tubes, T-cell lymphocytes in the upper epidermis, lengthened retiridges, and dermal capillaries dilatation. Okay, so this is all about the histopathology points of psoriatic plaques. So this is parakeratosis. You can see here this is the stratum corneum, and usually nuclei don't exist in stratum corneum, but here we are seeing that. So this is called parakeratosis. Next, we see clinical features. We see I already mentioned we will be seeing well-defined plaques, erythema, silvery scales, pitting of nails. I will show it again in next our slides. Joint swelling. Okay, take a look at this here. So this picture shows you very clearly about the psoriatic plaques. These are well-defined plaques. Erythema, you will be seeing redness in these. These are the silvery scales. Once you remove these scales, there will be bleeding from these scales underneath. So that is called positive aspect sign. Pitting of nails, and finally joint swelling and pain. So because psoriasis involves joint, so you will often be seeing joint swelling and pain, especially only in severe form of psoriasis. So what is aspect sign? Aspect sign, I already mentioned, when scales are removed, we get pinpoint bleeding. Why? Because epidermis is thin over dermal capillaries. Dermal capillaries have already dilated and epidermis is thin over them. So now once we remove the scales, we see a pinpoint bleeding. And then finally capillaries rupture when scale removed. They already got too much blood. Once we remove the scales, then that's blood start oozing out and we see aspect sign. Kovner phenomena. What exactly is Kovner phenomena? New lesions appear at the site of trauma. Once we see trauma, that we get a trauma, any kind of scratch, even any kind of injury, there we will after some time we will see psoriatic plaques formation. For example, at the point of scratch, surgical scar, burn, tattoos occurs after 7 to 14 days, because that's the amount usually that's the time which is needed by the immunity to develop. So that is to exaggerate the cell mediated, that whole process I already mentioned. So this is you can see here, this is these are the scar marks and scratch marks, but here we are seeing the psoriatic plaques. So okay, so this is the Kovner phenomena.